So 70-year-old female, she had a history of breast cancer, I think unrelated to the findings here, and just a follow-up CT.
It looks like something I showed a few weeks ago.
Yes. So the
Nice.
here, that was the arterial phase, so I can go back, go to the venous phase. CBT dilated, and we had this lobulated hypodense soft tissues surrounding the celiac axis and the retroperitoneum, surrounding the SMA, paravertebral. And as we go down, there's some soft tissue along the lumbosacral plexus, along the posterior margin of the psoas. And as we go down, we see this, that the neural foramina are widened, and again, enlargement of the nerves of the lumbosacral plexus.
Anyone
So for the rest
else want to guess? So plexiform neurofibroma and neurofibromatosis?
Yes, so they biopsied this, but this patient doesn't have, the only reason I had not presented it earlier, but when you showed it, then I thought, oh, it's very similar. This patient doesn't have history of neurofibromatosis. This was just incidentally detected, and they did a biopsy. This patient was 70 at this point of time when the scan was done. They biopsied this, and this turned out to be just schwannoma, basically a nerve sheath tumor. And she was a female, had history of breast cancer, and later she developed another breast nodule that was biopsied, and that also turned out to be a neurofibroma, is what they say on biopsy. So probably, right? I mean, but they don't give her a diagnosis of neurofibromatosis, and we don't see any cutaneous manifestations of it as well.
So interesting. I didn't realize schwannomas could do that too.
Yeah, so I that's what, like, is it some still a milder form of NF that they probably just never diagnosed? This patient was already 70, and after that they probably don't even worry that, I don't know, but an interesting case where we just saw like involvement of the plexus around the in the upper retroperitoneum, and then the dilated nerve roots along the lumbosacral plexus. And those classic findings that we otherwise see in neurofibromatosis, dilatation of the, like, enlargement of the neural foramina.
Nice. Yeah, there must be a spectrum of, presentations. Cool.
So this is a young patient. He's only 36. He came in after an MVC, and we were trying to see what was going on with his abdomen. Didn't we see anything acute? I think the only thing we did see was this cystic lesion in the sort of head of the pancreas region. The pancreatic duct is not dilated though, and we recommended an MRCP to better evaluate it. And so these are the MR images. So axial, post contrast.
Nelly, this is a companion to your case from a couple weeks ago.
Yeah.
So probably a type 3 choledococele.
Yeah, that's what we ended up calling it too. I think they did an EUS. After that, I can show you my PowerPoint. Okay. How do I show this? So choledochoceles. These are the images from their EUS. So they did see that cystic lesion, and I found that same image. So I guess, yeah, our differentials will still be broad. I mean, choledococele is what we ended up calling it, but I'm not really sure how to sort of tell these two apart from, I guess the frequency is obviously one thing that we consider because these are probably more common. But what we did find this other article that said, like, we've been calling these things all sorts of different names over the years. And I found that really funny and I put it in there.
Nice. Go back to your EUS, because actually when I showed that picture, somebody had brought up, would you be able to distinguish on EUS? Yes. And I do think if you, maybe if you talk to your gastroenterologist, because based on these pictures, I don't definitely see like a muscular layer on top of it. That one.
Yeah,
on the EUS, like I don't see like a thick muscle like on top of the cystic lesion.
Yeah, like not the gut signature.
Exactly.
Yeah.
So, but I wonder if we talk to our gastroenterologists, if they'd be able to, then say that, because they're used to looking for that muscle layer for gysts and stuff like that. So very cool. Thank you.
Yeah.
How do we treat these again? Like, what do they do for these?
So it's like, choledochoceles, they have this theoretical risk of cholangiocarcinoma because of chronic stasis. And so they usually try to do risk reducing surgery for most choledochoceles in a younger patient. We've had a patient who had a choledococele like this and who ended up getting a Whipple actually, because they could not separate it from the ampulla. But otherwise, I think they can, if it's like really just hanging off, they could just resect it.
Thanks.
Cool.
This is how the patient initially presented. There's hepatic steatosis. And then in the liver, it's kind of hard to see. This is a little bit of heterogeneity on the right. Patient had fever, abdominal pain, and this was the MR.
Wow. What was the time difference between that CT and MR?
5 days.
Wow.
And then here is the diffusion. ADC, it restricts. Oh, yeah. And then I'll give you the green. We don't have dynamics. I think it was something else. We don't have dynamics. So we're gonna have the green. And then here's the any thoughts? Yeah, I'll bring that back.
I'm thinking abscess. Can you show me the portal vein again? I just want to make sure
Yes.
it's like infiltrative malignancy with like.
Abscess, and I would venture that there's a good chance it's going to be Klebsiella.
There was like the middle hepatic vein was thrombosed. So we can't really see it here, but and that's right. That's what it turned out to be. It was a Klebsiella, and it was hepatic abscess. It was just like biopsied and proven to be an abscess. And I didn't know, but Klebsiella is a gut bacteria, and it secretes mucin that is apparently thrombogenic. So you can see that. So
it has a. If you go to MR, I think T2 showed it the best.
Oh, okay. Let me go
it
back.
So it has a turquoise sign.
What sign?
It's like maybe I'm not pronouncing this, but you know that color of that blue, pretty blue stone.
Oh, turquoise.
Yeah. So that's supposed to be pretty specific for like Klebsiella, where they have like these kind of like septations, which are like discontinuous and arborizing, and it's supposed to be fairly specific for Klebsiella, although I've seen them in non-Klebsiella abscesses. But based on the literature, it's fairly specific. It's pretty cool.
Yeah, nice job. I've never heard of that turquoise sign of liver abscess. And
That's
I
because
just
you didn't come to my lecture, Artie, at FAR.
oh, sorry. I was busy with a
Yeah, you
baby.
should be sorry.
Um,
I only know this because I had to create this lecture.
Oh, nice. And actually, I just Googled it and it says turquoise sign has a 96% specificity and 86% positive predictive value for Klebsiella. That's awesome.
Can you
Cool.
share your
Yes, but I
screen?
would take that. I would take that with a grain of salt because the bunch of cases that I saved to illustrate that sign, all of them were not with Klebsiella. So I would, it's not I don't think it's as perfect as literature makes it sound to me, but in this case it works.
Very cool. Okay, Gitanjali.
Yeah. Okay. So this patient is a 45, 46-year-old lady. She has history of Birt-Hogg-Dubé syndrome. And she had persistent rectal bleeding, increased vaginal bleeding. They did colonoscopy for rectal bleeding. They didn't find much, some areas of friable rectal mucosa, some external hemorrhoids, but other than that, nothing significant. Then I think they felt that there was some mass along the interior wall of the rectum, external. So they planned an exam under anesthesia, and both along with, because she had vaginal bleeding too, so both OB and colorectal surgery did this together. Again, they did rectal exam, they didn't find much. They thought that it might be something that's coming from uterus and ovaries. So they did a biopsy, probably I think they did a cervical biopsy, and everything turned out to be negative. So they got this pelvic MR done to see what that mass is, what's the origin. So these are the images here, sagittal T2. Axial, going from the top.
Maria in the chat is saying, is that a mushroom cap sign?
Do you have the
No.
coronal? It looks like I'm just trying to figure out where it's coming from.
I'm thinking the wall of the rectum.
I see a bowel. I think it's bowel, but I was able to clear the oves. So
That's the coronal. I think in axials, if you see, that's the
yeah, there's a small bowel loop right there, or there's a loop of bowel. Yep, yeah.
So
My guess is a gist, maybe, or I would be in that. Yeah, I would add that to the diff.
Yes, so, and that's the post-contrast. I'll just finish up the imaging on this one. That was diffusion, restricting mass, pretty restricting. That's post-contrast. So even I got gist, but there was something else also on this scan, and which was, if you see, the ovaries were multifollicular, and there was this heterogeneous enhancement here anteriorly, which is just cutting it off partly. And all that commental stranding was there along the anterior pelvis. I think if you see it.
Like for DIE, I would expect it to be more dark than this, which has more
what
gray.
really?
For DIE, a deep infiltrating endometriosis.
Yeah. But so that's what I mean. I thought that this was a gist, and I thought mental metastases were seen. So we said this is a mental enhancement nodularity here that needs workup, and we basically need more complete imaging of this area, like a CT, abdomen and pelvis, and see if where is this a mental thing coming from. But we raised concern for a mental metastasis. So interestingly, they biopsied this mass, and this turned out to be a serous carcinoma of ovarian origin and a low grade. So they did a complete CT, just abdomen and pelvis. And we have these multiple calcified omental nodules. And even this mass had a significant calcification, which we really didn't suspect on MR. So that was just a...
In retrospect, did you I felt like I saw both ovaries. So was it like
Yes.
exocytic from the ovary or?
I still think this probably is a met, because here we can see it's still in the wall of the, if you see the axial, it feels like it's in the wall of the colon or rectum. And I moved the axial.
And I think I see both ovaries. Like one has that. So that, is that
Yeah.
right-sided ovary? Is that the serous tumor? And then, because then the left ovary you can also see on the left side.
Yeah, and this is the left ovary.
Yeah,
which has
up there.
component, but yeah, we didn't suspect that it's coming from the ovaries because they seemed separate. And definitely it looked like it's still in the wall. And here also, like if you see lower down, isn't it splaying? This is the outer wall of the rectum, and this is that submucosal fat. So we thought it was a submucosal lesion in the rectum, which still it could be. Maybe it's a metastatic deposit in the rectal wall, but they still have to do. So they're planning for total abdominal hysterectomy and bilateral salpingoophorectomy. So once I have the final path that where is it arising from, I'll give the follow.
Maria actually brings up a good point in the chat, which she said serous usually comes from fallopian tubes.
Yes,
I
so they
remember,
might not be, yeah.
Yeah, like I remember Kate Maturin giving a lecture about this at SAR where she said like most ovarian cancers are actually from the stick cells of the fallopian tube.
Mm-hmm.
So that makes sense that maybe it's just interesting that like these ovaries look so weird and then that thing looks totally different than the ovary. It's like,
yeah. And the interesting part about the serous, I think I have it here. Let's see if I can.
And that it's low grade, but already metastatic. That's interesting.
Yeah. It is low grade, and I think this was interesting when we talked about serous. That's a difference between serous and mucinous. So they say that the low grade and high grade serous carcinomas have completely different histogenesis. Yeah, that's where they say. So it's BRAF and KRAS in borderline and low grade serous, whereas high grade serous is P53 and BRCA mutations. So they're like distinct histologic entities. So they completely like behave differently. And that's what they say, that's the low grade. No, I think it was the high grade that arises from the fallopian tube. So their origin might be different too.
Got it.
Yeah, it's somewhere in the text. I'll find it. Yeah, so that was like, even I think we called this as a gist with a mental metastasis, but turned out to be an ovarian malignancy. And that Berthold-Dubé was a completely a red herring, like I had no relationship with this.
Yeah, I was gonna say, does that, because this is a pretty young person.
Yeah, we searched up, we didn't find a single article that talks about increased incidence of ovarian lesions in Berthold-Dubé, so they're probably unrelated. The only other interesting thing was she was getting these follow-up MRs every year for renal tumors. And this was the MR 2 years ago. And I think it had this omental nodularity which we had missed. But other than that, her exam, like MR, was pretty negative.
Interesting. Thank you.
So that's one.
Nelly, do you want to go?
Okay. Patient presented with this 22-year-old. Yeah.
Needs a biopsy.
Yes.
Malignancy, I guess, less,
So-
or
so-
she's young, so adenoma
Material.
potentially, but it looks more
Venous.
aggressive to me.
And then I also have MR.
Looks really ugly.
Yes.
I would think about fibromyalgia here. Hemorrhage and everything.
And then we have
But I agree, needs a biopsy.
Maybe sarcoma also.
then there's the hepatomegaly. Yes, so this was biopsied and it came back as an adenoma. And let's see what it shows. Inflammatory subtype with mild atypia. And so then it went on to resection. I have to show this because it's and
And it was just an adenoma on resection?
no, It was an HCC that arose from an adenoma.
Can you
Nelly,
speak
what
up
did it just
one
say?
more time?
What did it say about the beta catenin on your thing?
Oh, so this was presented during the hepatobiliary red path conference. And the pathologist was saying, you know, there's this one pathologist that like really endorsed all of these subtypes of adenomas, inflammatory, you know, HNF1 alpha, et cetera, et cetera. He's like, but in reality, the only thing that matters is beta catenin activation. So as soon as we see that, or they see that pathologically, then this warrants resection. So
And so on the biopsy was the beta catenin positive, but negative, but on the final path it was positive. Is that what happened?
Oh, let me see. I don't, you know, I have to look up to see if the beta catenin was drawn on the, if it was done, but IHC, I didn't take that part of the path report. This presumably, it had atypia, and that's why it went on to resection. And it was an HCC. So patients with beta catenin activation adenomas, those are the ones that degenerate into HCC. That's from HCC. So presumably, I can look up the path report.
Awesome. Okay, I'm going to alternate with you.
In pathology,
41122.
differentiate between
Unchanged reticuloquadrant cyclial nodule.
differentiated
Period.
HCC.
No new suspicious findings. Period.
Victoria.
Victoria, can you mute?
Sorry about that.
That's okay. So Gitanjali, your question was, oops, I'm going to stop sharing. Your two questions that you had, one was if they're larger, they all tend to have HCC in them. I think that's why also like adenomas will be resected above a certain size, like 4 to 5 centimeters, because the risk of malignancy is much higher. And then what was the second question?
The other thing was whether, like in path articles, if you read the path section, even in radiology articles, they say that on pathology, it's hard to differentiate between adenomas with atypia from HCC. Something very similar to like in MSK, they say like if you give an osteoid tissue to a pathologist, they will not be able to exclude an osteosarcoma. So something on that line. So is it a pathology, this thing that then imaging takes over and says, hey, this is a big adenoma, it has to be HCC, or they're just not able to differentiate an adenoma with atypia from a well-differentiated HCC?
I've actually seen cases where on final pathology, they can't tell. So it's exactly what you're saying. Like they'll say, you know, atypical adenoma versus well-differentiated HCC, even when they have like the final path specimen. So I think, yeah, like that's probably why they resected it in this case. One, the size, it's very high risk. It had atypia. So it's going to be resected.
I have the data, or I don't know that it's clear to me, but this says beta catenin was negative for nuclear accumulation. However, glutamine synthetase stain showed intense staining, suggesting beta catenin activation. So it sounds like there was beta catenin activation on the biopsy, which led the patient to then get a partial amputation.
Cool. Okay, I'm going to share. Okay, so this is, I have an MR too, but what do you guys think about the gallbladder here?
Oh, it's that like IPNB of the gallbladder.
Yay, yeah. So it's like a carpeting, very polypoid, frondy looking lesion. I'll show you the MR too, because it's pretty. Here it is, very typical for this diagnosis, which is ICPN, intracholecystic papillary neoplasm, which is like the IPMN of the gallbladder. And here it is here. So you don't want to just call this multiple polyps. So this was resected and enhanced. I'll show you the post contrast. This is the subs. So you can see it's all enhancing, it's large. So this was resected and it was a 6 centimeter ICPN with several foci of invasive cancer. So in general, these are pre-malignant to malignant spectrum. 50% will have invasive cancer. So they actually have a better prognosis than a de novo gallbladder cancer. they tend to be kind of large and multifocal and papillary like this. And yeah, so this was a really pretty ICPN. And then one thing I wanted to show you guys is this is kind of semi-related. I was just talking to my fellows about it, is in radiology this year, they released new gallbladder polyp consensus guidelines. And the cool thing is that, so basically they say like, these are in low risk patients. So it can't be somebody that has a history of primary sclerosing cholangitis or in certain ethnic areas. But if this is just like a low risk patient who has a gallbladder polyp and it looks round, like a ball on wall appearance, that's extremely low risk, and you don't have to follow it up if it's less than or equal to 9 millimeters. So previously in our practice, we used to follow them above 6 millimeters, but their consensus is now that we can, like, there was a huge study that came out of a California Kaiser 20-year study with 620,000 patients, and they found that patients with gallbladder polyps had no increased risk of gallbladder cancer compared to the general population without gallbladder polyps. So we're getting less conservative in following these up. But once they start getting 10 to 14 millimeters, then they can overlap with pyloric gland adenomas as well as ICPNs. And then once it's above 15, then you could do surgical consult. There are some other categories just based on the morphology. So if it has a more broader stalk or sessile looking, then you have lower cutoffs for follow-up. And if it has thickening of the adjacent wall, then they should consider surgical consult.
Okay. Patients.
Is this like what used to be called a multilocular cystic nephroma, but now is in the category of MEST tumors?
Yes. That's right. So it's a Bosniak 3 and it was resected. And this is a cystic mixed epithelial stromal tumor or adult cystic nephroma. It's in the family, as you said, it's the mixed epithelial stromal tumor MEST family. So it's a Bosniak 3, and I think when we had presented this case, we said it's Bosniak 3, but MEST is in the differential, which is benign. And so then the urologist is like, like they're like, well, Bosniak 3, right? I mean, most of Bosniak 3 patients, like 50 to 60% become or harbor cystic RCC. So it was a little bit hard because you kind of want to preserve the kidney because MEST can look like this, but I don't think we can tell by imaging and differentiate those two entities. So this patient was young, and so went on to get a resected and came back.
Did they do a full nephrectomy? Can you scroll through again? Like,
Yeah.
I'm wondering if we bring up MEST, if they could do like a intra-op frozen and try to save the kidney.
A full nephrectomy was done because it was a large mass, cystic lesion. And does intraoperative kind of path evaluation, is that diagnostic for MEST? I don't know. I didn't know there was a role for intraoperative, but and MEST was raised.
I mean, I've never, but I've seen now several of these like MEST resected, and they're usually big and like herniating into the renal pelvis like this one is. So anything involving the renal pelvis usually gets a full nephrectomy. But I wonder if they could do like a partial with the frozen, because on frozen, a MEST is going to look totally different than an RCC. I think they're not like cousins, like, the adenoma HCC kind of thing.
No, that's a great thought. I didn't even think to suggest it because that's a good point, right? I mean, then you can at least at minimum spare the normal kidney.
Yeah, there's so much kidney there.
It's so sad.
Yeah. Okay, so this is my next one. So you can see that there's severe biliary dilation and these large CBD stones. Sorry, keeps doing this for some reason. Okay, here it is. probably some of the biggest CBD and stones that I've seen. Cystic duct remnant was also dilated. But the interesting part of this case was also, this is the arterial phase. So what do you guys think is going on? So we have a very geographic perfusion abnormality. The left lobe is brighter than the right lobe. So I always tell my residents in the liver, whenever you have a brighter segment or lobe, that's the abnormal one, because it means the hepatic artery might have been activated and taken over, and it's called the hepatic arterial buffer response. So you have to look carefully at the veins. And so here we can see that the left portal vein is completely thrombosed. So if we go to the venous phase, you can see like this is the right portal vein, and then the left coming off, it's kind of blending in with this bile. So this is the bile duct, and then this is the thrombosed left portal vein, and then this is the venous phase. We can see the nice right portal vein, and then this bland thrombus filling the left portal vein and its branches. So for the trainees, this is just what you'll see. It's called the hepatic arterial buffer response, and you see it best on the arterial phase, the arteries taking over to try to save that lobe. So we thought in this case that there was probably cholangitis. We've got a lot of peribiliary enhancement, and that cholangitis did also lead to this left portal vein thrombus. Okay, I want one of the residents or fellows to tell me what is going on with this patient.
I see reflux, like it's,
Yep, so contrast is refluxing from the heart into the hepatic veins and also into the kidney. Anything else?
so large wedge-shaped defects. I mean, consolidations.
Uh-huh.
Is the patient alive?
No, so that's actually the diagnosis here. So this patient had passed away, and nobody had realized it, and so they did the scan. So you can see the heart is not pumping, which is why we've got this level here, this layer. You also have a level in the IVC. So the injected contrast is basically just layering in here. So if you see that layering and reflux and all that stuff, you should go check on the patient immediately.
So they died in the scanner?
Yeah, they actually think they died probably before, but people thought they were sleeping, and so transported them to CT and scanned, and then we saw this.
Wait,
Yeah.
they weren't on a monitor or anything like that?
No, they were like
Wow.
on a regular floor.
Oh
So
my goodness.
I've seen this several times now, which isn't boding well for transporters, but I also want to give one caveat. I saw this once, like very similar to this, and I was like, oh my God, the patient might be dead, or coded on the table, and we ran to the scanner and the patient was fine. And so even though I thought this was sort of like pathognomonic for code, you can see this if they inject, in the patient that I saw that in, they had a femoral central line, and they had injected through the femoral line, which was like, I think the tip was somewhere in the IVC. And so it kind of like shot up the IVC, but since it was going in like the opposite direction, it kind of like layered like this and it refluxed. So that's just one caveat. It wasn't layering in the heart, but it was like layering and refluxing in the IVC. So it's not pathognomonic if you inject through the femoral vein.
But I think the heart, I think the heart is fairly pathognomonic.
Yeah. Okay, so this patient got a testicular ultrasound. The testicles are somewhat small, and they bilaterally had multiple small hypoechoic lesions in them. So what's your differential? Anyone? Oh, there's something in the chat. Maria says sarcoid and adrenal rests. Excellent. So we thought about that. They did not have congenital adrenal hyperplasia or any other history of anything like that. So these were not adrenal rests, but that's a great thought. They didn't have a history of sarcoid. Other things we can think about is mumps, TB, lymphoma, metastases. It was none of that. Maria also says lymphoma, excellent, but it was not that. This is something my colleague showed us this case, and I'd not heard of this, so I thought it was interesting. One clue is that they did the scan because their testosterone was low and they were having issues with infertility. So this is something called Leydig cell hyperplasia, which is a rare tumor. It's hard to differentiate it, on imaging from anything else. So they basically have to do a biopsy. In this case, they did a surgical exploration and testicular biopsy, and it came back Leydig cell hyperplasia. Leydig cells produce testosterone, but when you get Leydig cell hyperplasia, it makes so much testosterone that and it also makes aromatase. So the testosterone actually gets converted to estradiol. So the patients, this is more common in children, and they might have precocious puberty as well as gynecomastia. Another thing, because of the low testosterone, is they can develop osteoporosis. So this patient also had low bone mineral density as well as low testosterone. And so this is a benign condition. It doesn't need to be resected. It's unclear its relationship with Leydig cell tumors. People think they might be two separate entities, not that this hyperplasia turns into a Leydig cell tumor. So they usually treat them conservatively, but might do testosterone supplementation. So I'd never heard of it or seen it, but if you see small little hypoechoic masses, they do need to be biopsied, but it could be Leydig cell hyperplasia, especially if the patient has low testosterone.